from the American Academy of Pediatrics.
Healthcare coverage for children in the United States can be complicated and confusing.
An updated policy statement looks at ways to revamp the system, starting with Medicaid.
We should also try to make sure that children who are in publicly funded programs like Medicaid have access to the same types of primary care and subspecialty care as their privately insured counterparts.
Plus, new research in the journal Pediatrics examined charging for messages through patient portals.
It's important not to disregard this as this is just a power grab or a money grab. There is a real impetus to say we are doing all of this effort. What are the reasonable approaches to it?
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about financing child health care.
David, do you remember when Mira got her leg stuck in a bike tire last summer?
Oh, how could I forget? She had such a nasty third-degree burn on her leg, but I was thankful she didn't break any bones and healed up well.
I mean, for how bad it could have been, she recovered from the wound and was up and in a walking boot around about a week. I was so impressed with her healing and her attitude. But do you know what I'm still reeling from? The hospital bill.
Wait. Was it not covered by your insurance?
No, not at all. I have a high deductible plan with a health savings account my employer feeds into to encourage the high deductible plan, but it doesn't cover any emergency medical bills outside of state.
No.
And she needed those emergency services. So it was sort of a shock for my husband and me.
I bet it was. I think a lot of people get surprised about what their insurance will or will not cover, or maybe they find themselves confused about insurance enrollment, how to do it, what plan to choose. That's why I'm glad the AAP is updating a policy statement on the principles of child health care financing. And we have the lead author, Dr. Alison Galbraith, here to discuss.
Dr. Galbraith is a professor of pediatrics at Boston Medical Center and Boston University School of Medicine. She is a researcher who focuses on health insurance policy. Alison, welcome to the show.
Hi, it's great to be here.
All right, so let's start with the basics. How does health insurance work for children in America? Who has it, who doesn't, and where do they get it from?
Well, that's part of the problem, that the system is very mishmash, a hodgepodge of a lot of different types of insurance that don't reach everyone. So there's commercial insurance coverage that maybe covers about half of all kids through a parent's employer. And then there's the Medicaid program, which is public coverage, and maybe almost an increasing number of children are covered on that. And then some children don't have insurance, and those are often kids who are undocumented or kids who are low income or can't afford coverage, and that's also problematic. And so, we have this hodgepodge system, and it's hard if you're trying to find insurance, it can be really hard to find it. It's hard to know how to find it. It's hard to understand the different types of plan options. If you lose it, it's hard to get back on it again. And so I think in this statement, we really think that it's important that children across a range of ages have access to quality, affordable, continuous health insurance coverage.
And how many kids in the U.S. are currently uninsured?
Well, that has changed. Coverage rates for children have been variable over time, and it dropped a lot after the Affordable Care Act. So there was a historic low of about 4% uninsured in 2016, but then coming closer towards 2020, it was more like 5.6%. And more recently, a lot of kids were covered as kids were allowed to stay on Medicaid during the public health emergency. And then now that that's ending, a lot of kids are churning on and off as that's been happening.
And the policy statement you released goes through 6 different principles of healthcare financing. One of the first concepts is this concept of universal healthcare for kids. And universal healthcare has been somewhat elusive in the United States. Up to what age should children ideally be insured?
Well, so this statement, we call out and say that we think that, children, adolescent, and young adults should have coverage from birth to age 26. And, that's that's a little bit pushing the envelope on the age, but I think there's, transition can happen from adolescent to young adult at a range of ages, and it's really important to have coverage during that time. So I think that's really important that is in this statement.
And how do you envision we could achieve universal healthcare coverage here in the United States?
Well, so this policy statement is its principles. It's more high level and aspirational, that's the goal, is that everyone should have quality, affordable health insurance coverage. And we're not really going out there to say, mechanistically, this is how it should be done. In part because I think, it leaves some flexibility around how do we do that? Like, however we can get all kids covered with good quality insurance that covers things like your daughter. I assume that's your daughter you're talking
Mira's
about.
My 5-year-old.
Yeah, that covers the things that she needed. That's good. So we don't, this statement isn't saying how exactly that should happen.
I think some people sort of visualize healthcare as being divided between primary or preventive care versus more comprehensive tertiary or even quaternary care for kids with a lot of healthcare needs. In terms of the finances for these things, how can these different types of care be made accessible and affordable for everyone?
Well, it's a really important thing because you're right, they're two really different things. And some of them are predictable and regular, like having your well child checks, and some of them are less predictable, like someone who, gets in a car accident or something like that. And some of them are maybe a little more predictable, but still really high cost, like quaternary care for a kid with a really complex set of conditions. And so it's important that whatever package or set of benefits that children have in whatever program should reflect that range. I mean, and that's the EPSDT, the early and periodic screening, diagnostic and treatment model, kind of basically says that whatever is medically necessary for kids is supposed to be covered. And that's the model, in theory, that Medicaid is supposed to provide. We could argue about whether they actually do that. And, that would be the model that we are espousing here in this statement, that like all benefits for children should kind of approach it that way. Again, aspirational.
And the policy statement brings up this concept of cost sharing. What exactly is cost sharing, and what are ways that costs can be kept down for families accessing needed health care for their kids?
Yeah. So, I mean, you had that experience that you related that, I think the point, especially in these high deductible plans, is that, the theory is that if people have to pay some of the cost of care, so they have to share the cost, right? They have to pay copay, they have to pay a deductible, then maybe people will be better consumers and not use care that they don't really need, or less like more elective stuff. But, it's really hard to be a consumer in healthcare. It's not really a consumer good. And so it doesn't end up working out very well. And so there needs to be some parameters around that. We say in this statement that there should be limits to how much people have to pay out of pocket. And those need to be reasonable, and they need to account for family income, right? Like a family that has a low income needs a pretty low out-of-pocket limit, because you don't want people to not get care they need. And especially in programs for low-income families like Medicaid and CHIP, that there really should be no cost sharing in those programs.
We know that in pediatrics, reimbursements from insurance companies are not as substantial as for similar adult services. That has never made any sense to me, and I'm med-peds. Are there ways we can change this inequity?
So there are two interesting things about this statement that address that issue that you raised. One is that we call out that, reimbursement for pediatric services should not be less than what you would pay an adult doctor. And it should be not different between what you would pay for a kid with Medicaid and a kid with commercial insurance. If you're doing an appendectomy on a kid and an appendectomy on an adult, like, why should that be paid differently? The other thing that the statement also adds in is to talk about how important it is to think about the unique attributes of children when designing financing systems. So, for example, there's a lot of, say, risk adjustment that goes into alternate payment models that comes from adult risk adjustment algorithms, and that needs to be different for children. And so, and when an insurance plan is trying to set rates or something, there needs to be a pediatrician sitting at the table saying, oh, but what about this for kids? So it's important both to understand the children are unique, but also that to make sure that care for children is not treated differently or less than care for adults.
And the AAP as an organization is committed to dismantling healthcare disparities. And when it comes to healthcare financing, how can we make sure that historically minoritized groups of people get access to quality, comprehensive healthcare?
So one thing that we tried to do in this statement was we added a section to talk about equity and how healthcare financing can promote equity. And there are a lot of inequities related to the way health insurance policy is structured. For example, in the Medicaid program, there are a lot of differences across states that affect how racial and ethnic disparities play out. And so some states might not reimburse very well for seeing Medicaid patients. And as a result, there are a lot of kids who have to travel really far to get care or don't get as good of care. And I think that if we can try to make more uniform a program like the Medicaid program at a federal level, that might address some of these structural state-based forces that lead to some of these inequities. Some other issues that we raise that contribute to inequities that we think that healthcare financing can address is to make sure that there's a way for immigrant children, regardless of documentation status, that they have some sort of insurance program that they can have access to. And then secondarily, we should also try to make sure that children who are in publicly funded programs like Medicaid have access to the same types of primary care and subspecialty care as their privately insured counterparts. And again, this is structural, right? So if we can make that more equitable in the Medicaid program, that would actually help a lot of the racial and ethnic disparities and income disparities we see.
You know, so much of pediatrics is about preventive medicine. I mean, we see kids when they're young to ensure that they're healthy for their entire lives going forward. Is there a way that healthcare financing can reward the incredible jobs pediatricians do, keeping kids from getting sick and needing to access more expensive healthcare services for decades out?
Yeah, I think it's really important to think about, especially there are more and more alternate payment models, and we're trying to pay for value in payment to providers. I think that being able to provide really good preventive care should be rewarded with, that we should pay for that adequately. And, we also need to think about that a lot of the work we do as pediatricians, the return on investment is long, and it might not pay off within a year or two for whichever commercial insurance company is covering a child, or even a given state's Medicaid policy, over the course of a child's life. But if we invest in preventive care early, we'll see the return on investment later. And we have to think about that when we're paying for it.
There's just so much to talk about here, but putting your money where your mouth is, do you have one last takeaway for our listeners?
I think one of the most important things right now is trying to reform Medicaid because it covers so many children, such a large proportion of children. It's where a lot of inequities come from. It's where a lot of pain points are for providers. And I think that addressing Medicaid reform, I think, would be really important. And I think that this statement, again, is meant to be high-level principles and not how-to, but I think it's a great tool, for example, for the AAP's advocacy team to then use to advocate for specific policies as they come up.
Dr. Alison Galbraith, thank you so much for joining us today.
Thank you so much. It's a pleasure.
To read the new AAP policy statement, Principles of Child Healthcare Financing, visit our website at aap.org/podcast.
Coming up, we'll look at the pros and cons of charging for messages through the patient portal.
When I did general pediatrics, the phone calls at the end of the day were so time-consuming. I'd finish clinic at like 5:30 or 6 p.m. and then be on the phone answering questions and documenting conversations until well after 7 many nights. Of course, back then, nobody used patient portals for messaging.
I'm picturing you, David, on one of those rotary dial phones. Just like reaching out to everyone. I remember those days, and I have to say, I'm so happy to just be able to message my kid's pediatrician and get an answer back on the portal.
No, wait. Do they charge you for that?
Not yet, but I've heard that more organizations are starting to, or at least threaten it. I can see why, given how time-consuming it can be with patients. And then again, I'd hate to think of patients deciding not to communicate because of the cost.
Oh, me too. A New Perspective in Pediatrics explores exactly that question, and today we get to talk with Dr. Bryan Sisk, the author of the article, The Harms and Benefits of Billing for Patient Portal Messages.
Dr. Sisk is an assistant professor of pediatrics in the Division of Hematology and Oncology at the Washington University School of Medicine. Bryan, welcome to the show.
Thank you. Happy to be here.
So, Bryan, let's talk first about patient portals in general. How are people using them, and how has that been changing over time?
Yeah, it's a great question. Like you said in the intro, it used to be phone calls. And with the 21st Century Cures Act, which is a law that said hospitals aren't able to block patients from seeing their own medical records, that's really led to all of these hospital systems creating online portals as the way people can get in. So to answer your question, part of it is there are people that are very engaged that are accessing the records, for parents, for example, accessing their kids' notes or lab values or medical records, and also using them to send messages to doctors. There's also a large number of patients who aren't aware or aren't interested or aren't using it. So it's both well utilized by some patients and then also just really underutilized in other areas where it could potentially be beneficial.
And what about this trend of charging for messages? Are a lot of places starting to do that?
More and more across the country. My institution here just started about a month ago. There's been news reports of different centers around the country doing it. There's been some centers in the pediatric world who have started and then reverse trend and undid it after a few months. So it is becoming more and more of not the norm, but it's becoming more and more prevalent around the country.
And does insurance cover those charges?
I think there's a lot of unknowns about exactly what the charge will be, exactly how much it's going to cost. Insurance presumably would cover them, but it's uncertain if that would still have a copay. There's actually a lot of uncertainties around this. For example, my institution has the ability to bill for portal messaging now, but I don't actually even know how to do it. Maybe they want me to know, but I think there's a lot of uncertainty with that. There's a lot of uncertainty from the parent's perspective, when they write a message and get a response that says you might be billed for portal message. There's a uncertainty of, am I actually being billed for this? How much is it going to cost? Is there a copay? Are you charging me for every message? Are you charging me if my teenager writes a message? There's a lot of things that we don't actually, at least I don't through my research, know yet.
And you mentioned some hospitals started it and then walked that back. Do you know why they would have stopped charging for portal messages?
So I haven't spoken with them directly. The people I've spoken with about that, it ended up a lot of the billable encounters weren't actually being billed. So some hospitals, as low as 1% of the encounters that could be billed were being billed. And I suspect it led to some frustration or backlash with some parents.
For your article, you surveyed your colleagues in pediatric hematology and oncology to get their thoughts on patient portal messages and billing. What did they tell you?
So there was a wide array. On one end, there were people that were very worried that it was creating a barrier to communication, especially in oncology, where if you have a patient who has, for example, a fever or bad diarrhea, waiting a few hours too long could end up in the ICU, could end up being even sicker than that. So there is a lot of concern from some of my colleagues about creating that barrier that makes it more likely somebody's going to be afraid to call because of whatever reason, whether it's financial or just frustration with the process. On the other end, there were people who said, as doctors, as pediatricians, we are really the only profession that doesn't charge for all of the time that we're spending doing things. And so if you've got a lawyer, they're going to let you know the bill when they're responding to your voicemails and to your emails. As kind of a funny aside, I was talking to one person who brought that up and said actually they had a relative going through a legal process and was using that as an example of, they documented to the minute every email, every phone call. And so, it's not unreasonable to bill. I did end that by saying, what did you think about that lawyer? And she said, I hated him. So there is that caveat to it.
You brought up barriers. How concerned are you about inequities in the use of portal messaging? Is charging for something like this going to make patients who already have healthcare access issues even harder to reach?
That's my big concern is we've got this big multi-billion-dollar tool of a portal that has a lot of potential in it. And we already know there are plenty of reports showing that there's disparities along racial and ethnic and sociodemographic lines of which patients and parents are more likely to use it versus less. And so if you compound that with concerns about receiving a bill, it might make those folks even less likely. The other thing, I was talking to a friend of mine who has a child that sees a doctor, and they wrote a message to the doctor and got this message back. And she gave me a really interesting perspective. Before she had sent that portal message, the doctor had really emphasized, we want open, clear communication. Feel free to reach out at any time. Always happy to communicate. We love using the portal. And then she went and sent the portal message and got a notification back and said, by the way, we're going to bill you. And it made her think, was he telling me that because he wanted to be a good communicator or because he wanted me to do this billable, expense? And so I think it's not an unreasonable approach, but that is one of the other risks of, does it influence even the way that you look at good faith efforts to communicate by your pediatrician?
If there's a clinic that isn't sure what they want to do about portal messages, are there ways they can change their workflows going forward to decrease the burden of this electronic conundrum?
Yeah, I think to take a step back, you raise a really important point, which is why are hospitals doing this in the first place? And the reason is because there's been such an increase in the use of portal messages. And with COVID, aligning with the time when portals really became popular, messaging volumes went up 50% in some centers. And if you add that on to the task either of having physicians respond to even more of those or having to hire additional nursing hours to respond to those, that's a cost that doesn't have a revenue stream. And so it's important not to disregard this as this is just a power grab or a money grab. There is a real impetus to say we are doing all of this effort. What are the reasonable approaches to it? I think that there are ways that hospitals can try to offload some of that burden. The ones that come to mind initially in the current state would be things like, could you have more availability for telehealth visits to make it a little easier for patients to request or generate these telehealth visits, which are more clearly like what a clinic visit is? Are there ways that you can triage, whether it's using artificial intelligence or something else, triage when very serious issues are arising that need to be addressed more quickly versus ones that can wait, so that you can triage your workload a little bit better? Are there ways that you can put in character word limits? It's not a guarantee, but if somebody can't write 5 paragraphs and has to keep it in 1 paragraph, potentially that could help them to kind of focus their thoughts. Yeah, I think looking at the future, the real question is, what are the types of messages patients are sending? And each type of message is going to potentially have a different response. Specific questions about, should I take this medication or what should I do for this? Those are going to need a clinician. But there might be general knowledge questions that we could use information repositories or chatbots or things like that to give more informational data and remove that burden from that portal flow. So I think there's things that can be done, but it is a hard problem because you want to make sure you maintain that high quality whenever you're communicating with patients.
Well, this has certainly been a really interesting discussion. Is there one last takeaway you'd like to leave our listeners with before they go check their portal messages?
I think my last takeaway is that communication, no matter what form it takes, is really important to patients. And as physicians, when new technologies come into our workflow, we need to be proactive about both making sure that they're benefiting patients and us, but also making sure that we're evolving our role with that technology so we can maintain a central role in helping our patients become better. I think we need to embrace technology and make sure that we're part of determining what our role is in incorporating that technology.
I love that. Embrace it, shape it, take charge. All great advice. Dr. Bryan Sisk, thank you for joining us.
It's been a pleasure. Thank you.
To read the perspective, the harms and benefits of billing for patient portal messages, go to aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
Okay, I'm going to be a total AAP geek, but the North Carolina Pediatric Society had their annual meeting here in Wilmington for only the second time ever, and everybody got to come to my city. Usually I'm going somewhere with them, and it's always extraordinary because it's a chance to catch up with so many people that I trained with or know from the state and hear stories from our leaders from all the years, and of course, learn some stuff and eat some hotel buffet food. But it just felt so special to be the host this time and be like, oh, let me tell you 20 places to go to dinner. It's just like...
Oh, it's so fun.
It was
yeah.
great.
I'm sure it was just beachy because I know Wilmington's on a beach.
Yeah, like that.
My say is also a little AAP geekiness in that, I visited headquarters for the very first time ever, David. I actually saw, where the magic happens in the AAP building. I got to see our producer, Ann Johnsos. I got to do a little filming work, which I just had so much fun doing because there's such an amazing crew of people out there in Itasca. And I got to see the fountain and walk a little bit of the campus. It was actually really magical. It's a beautiful kind of headquarters. And it's fun when you tell people you're going to HQ,
It makes great photographs from across the lake. By the way.
Yes. And it's very well
centers.
lit in there. Yeah. Good windows.
Oh, fun. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll look at corporal punishment in schools.
We'll talk to one of the authors of a new policy statement, Dr. Mandy Allison. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening.